I'm Tim Markle. I work with the Wisconsin Youth Health Transition Initiative. First, we like to start with a few reminders. During the call, any background noise and conversations that are not muted on your line may become part of this archive presentation and may prove distracting. You can control this in the Zoom conference room using the mute feature located in the lower left corner of the window. For this call, we will be looking for interaction and we welcome questions, comments, and clarifications at the end of the presentation. At the end of the presentation, please unmute yourself when you want to talk. If you have a problem unmuting yourself and you think that it is a problem on my end, please put that in the chat box and I will see what we can do. Due to the number of attendees and to help us track attendance, please put your name and organization in the chat box so everyone knows who is here. This presentation and accompanying materials will be available at a later date on the Health Transition website under the Learning Community tab. At the end of the call today, please complete the evaluation at the link that will be provided in the chat box. If you leave the call early, and even if you don't leave the call early, the link will be sent to you. We would especially appreciate if you could rank the possible topics for future learning community calls in the order of your interest, which is part of the evaluation. This helps us continue to provide interesting topics and quality of content to our healthcare transition champions like you. But before we begin, we would like you to know of some exciting additions to the Youth Health Transitions team. At our last learning community, the team included myself, along with Ann Harris, who is the project lead, and Lynn Robick, who is our evaluator. We now have a new coordinator, Beth Moss. Beth, would you please introduce yourself?
Thank you, Tim. My name is Beth Moss, and I am the parent of a 26-year-old young adult with autism, and also a 25-year-old adult who is a new social worker. I'm really looking forward to learning with you on the learning community calls in the future, and also to planning future calls that interest and are relevant to your work.
Thank you so much, Beth. It's great to have another team member, and it's great to have someone with the experience that you bring. We also welcome Julie Hajewski, who is going to try to be on the call. Julie will be working with our medical professionals. Julie, have you been able to make the call? Okay, I don't see your name on the board, so we're going to assume that, something, how clinics can go, and so the clinic may be overrun. So hopefully she'll be able to join us and introduce herself a little bit later. Anne, did you want to take a moment, though, to say a couple words about Julie and the addition of Julie to our team?
Yes, thank you. Julie Hajewski is an adult nurse practitioner in a primary and an internal medicine primary care practice, and she's going to help us work with our healthcare providers, both pediatric and adult providers, to help them make connections with adult providers and work specifically on things that their clinics can do to promote better youth health transition practices. So again, if Julie comes on later, she can say hi.
Thank you so much, Anne. Today, we'll be learning about and discussing supporting self-management in children and adolescents with complex chronic conditions. We plan to spend about 40 minutes learning about supporting self-management and then having a discussion among ourselves. We'll monitor the chat box throughout the presentation, so if you're in a place where you can't talk or if you'd rather type your questions into the Zoom chat box, please feel free to use that. Any questions that are not addressed during the presentation will be part of our Q&A at the end. With that, it is my pleasure to introduce Melissa Novotny. Melissa is with the Pediatric Complex Care Program and Pediatric Cerebral Palsy Clinic at American Family Children's Hospital. She will discuss her article, Supporting Self-Management in Children and Adolescents with Complex Chronic Conditions, which was part of the supplement in Pediatrics, Building Systems that Work for Children with Complex Care Needs, published February 21st. Welcome, Melissa.
Hi, everyone. Thanks, Tim, for having me here today. It was a nice introduction into the presentation that I'm going to give and a little bit of my background. So again, I'm first just going to give a presentation on this, and then there'll definitely be time for questions and discussion that I hope will be lively at the end. So just a little bit about me and my background. Again, I'm a nurse practitioner at the PEDS Complex Care Program here at the American Family Children's Hospital. And our program provides enhanced medical co-management and coordinated care for children with medical complexity that often involve multiple medical and surgical specialties. The patients we take care of range from infants all the way up until late adolescence. with a wide variety of medical conditions, functioning along a broad spectrum of cognitive, developmental, and physical abilities. We provide both inpatient and outpatient services and support. And an important aspect of our program is our ability to build relationships with our patients and their caregivers so we can help them build self-management skills as they navigate their complex medical conditions over time. Here are some objectives I just want to go over. So participants attending today will be able to define self-management and self-management support, describe key differences between self-management in children and adolescents and adults with medical complexity, identify 2 proposed frameworks or approaches to pediatric self-management, and discuss other approaches and tools used to support self-management in the medically complex patient population. So the inspiration for this presentation came from a journal article. It's not my journal article, but it's by Paula Lozano and Amy Houtro, and it's on supporting self-management in children with complex chronic conditions. I'm going to review what the authors covered in this article, and then I'm going to review some tools that I specifically use on a day-to-day basis to support my patient and caregivers in self-management. For purposes of this presentation, when I am referring to children, I am referring to both children and adolescents. It's just easier to say that over the course of this presentation. So to give a little background or the importance, as most recommendations in healthcare, I think it's important that we ask ourselves, why is self-management important or necessary for this population? First of all, in the past 2 decades, the rate of chronic conditions among children has doubled, and it is estimated that approximately 13 to 27% of children in the US have a chronic condition requiring ongoing treatments throughout their lives. Furthermore, with advances in medical interventions and technology that effectively treat a wide range of previously fatal conditions, more and more children with disabilities are now living well into adulthood. And as a result, children and their caregivers are responsible for managing complex treatment regimens. We also know that children with medical complexity are at a high risk for adverse outcomes, including medical, developmental, psychosocial, and family outcomes. And research has demonstrated a high prevalence of poor self-management and non-adherence across pediatric conditions. So with the prevalence of chronic conditions in childhood, there is an increasing need for children to learn how to effectively manage their health conditions. Self-management is a complex behavior, and I am by no means an expert in self-management, and I'm continuously learning more and more about self-management myself and how to build it into my everyday practice. Here's one definition of self-management. Self-management can be defined as the set of behaviors that people engage in as part of living with a chronic health condition. And self-management includes a set of common tasks that aim at optimizing the child's health and well-being. The outline box below here provides examples of these common tasks that include things like monitoring symptoms, managing medication, or taking steps to prevent complications. And then these tasks fall along a spectrum. On one end of the spectrum, there are behaviors that are directly related to healthcare, and examples of these type of behaviors would include checking one's blood glucose or eating a low sodium diet or being able to swallow a pill. And then on the other end of the spectrum, there's social and lifestyle behaviors that both impact and are impacted by wellness. And these would include behaviors such as attending school, trying out for a sport, or seeing a counselor, for example. And then there's self-management support. And this refers to the services that health systems and community agencies provide to children and their families to facilitate self-management. And this is truly a collaboration between the child, the caregiver, family, and the care providers. And much of my talk today is going to focus on this self-management support. I think it is important to note that effective self-management has the potential to improve adherence to treatment plans, treatment efficacy, health outcomes. It has the potential to improve the individual's capacity to navigate challenges and think critically. and improve quality of life and self-worth. It also has the potential to reduce morbidity, ER visits, and overall healthcare costs, which is pretty cool. With the adult patient population, research has demonstrated that effective self-management support is indeed associated with improved health outcomes and patient experience. And self-management support is a pretty well-established part of high quality of care with adults with chronic conditions. And there are care models and evidence-based practices available in aiding and supporting self-management in adults. However, in contrast to the adult patient population, models and practices are not as well developed for children, and self-management support is not as readily integrated into pediatric care. One aim of this journal article was to help decrease this gap between the well-developed area of adult self-management support and the more sparse field of self-management in pediatrics. There are three key differences between children and adults that I think can help explain this gap and are outlined nicely in this article. The first is regarding dependency. While there are definitely adults with severe illness or disability that rely heavily on caregivers, most chronically ill adults have a lot of autonomy in their lives. Most chronically ill children, however, depend on caregivers for some or all of their cares. And unlike adults, parents and healthcare providers play a significant role in the child's self-development because they are the ones that are ultimately responsible for the child's health and well-being. So really, in pediatric, self-management should be referred to as shared management between the child and caregiver. The second key difference is regarding development. Among children, there is a wide spectrum across all ages and areas of development, including emotional, social, physical, and cognitive development. And children are unique because over the course of their childhood, they experience multiple periods of significant developmental changes and major life-related transitions. So it is important to note that a child's capacity for self-management is always evolving. And the third key difference has to do with epidemiology, or the nature of the chronic illness among the two populations. In children, there are a vast array of rare conditions that are responsible for chronic illness, whereas in adults, a small number of diagnoses make up the majority of chronic illnesses, like diabetes, hypertension, or high cholesterol. This small number allows primary care providers to become pretty proficient in managing adult chronic conditions, whereas pediatricians often must rely on subspecialists to provide some portion of care to children with medical complexity. The unfortunate consequence of this is that health systems often tend to create silos for different pediatric conditions compared to the more generic approach that is taken with adults with chronic illness. So ultimately, pediatric healthcare providers need standardized approaches and tools to support self-management. And they specifically need tools to, here I have them listed, assess the self-management skills of youth and caregivers, assess modifiable environmental influences on their chronic conditions, collaboratively set self-management goals, and tools to help promote competence and eventual autonomy among youth. To address the unique needs of pediatric patients, this journal article highlights two comprehensive conceptual frameworks that can help us approach self-management support with our patients and families. These two frameworks have the potential to be effective for two main reasons. First, they take a broad approach to pediatric chronic conditions instead of being diagnosis specific. And second, they steer us to evaluate the multiple systems, environments, and influences that impact the child and family. The first framework is Avani Modi's self-management model. This model clarifies the mechanisms and processes that influence self-management, adherence, and ultimately the child's health outcomes. If you look at the left side of the figure at the circle, this model contains three interdependent parts. The three parts include, so you have the individual self-management behaviors, that's in the center of the circle. Then there's the contextual variables, and these are also known as modifiable and non-modifiable influences. And they go across the four domains of the individual, family, healthcare system, and community. These modifiable and non-modifiable influences impact the execution of the self-management behaviors. These influences can either promote or hinder a child from performing self-management behaviors. And then the third part of the circle includes processes, and these can be cognitive, emotional, or social processes that link the influence with self-management behaviors. Within each of these 4 domains, the child's developmental level may impact how influences and processes manifest. Then, looking towards the right side of the figure, the degree to which self-management behavior affects adherence and ultimately outcomes may result in changes in self-management behaviors. This figure here, this is the World Health Organization's International Classification of Functioning, Disability, and Health. And this model provides a common framework for considering functioning and disability in the context of the child's health conditions and contextual factors. The model is centered on 3 core components of functioning. First, you have the body function, or in other words, the child's physiology. Second, you have activities, or this is the child's skills and abilities. And then you have the participation. So this is the child's use of the skills or their abilities. There are then contextual factors, which include both environmental factors and personal factors that influence functioning in complex and dynamic ways. Furthermore, this model distinguishes between 2 features of the activities and participation. And these 2 things include capacity and performance. Go on to the next slide here. And so again, this model steers us looking at the capacity and performance of a child. So with capacity, this is also known as capability. You are assessing what the child can actually do. Whereas with performance, you are assessing what the child actually does. If, when looking at the capacity and performance of a child, we notice that the child's capacity or their capability exceeds their performance, this model proposes that we need to assess for potential barriers in the environment or personal context and determine if these can be modified or overcome. A key feature of both of these frameworks is that they guide us in taking into account the influence of the environment on the child's health and self-management. Modi's framework specifically wants us to look at the environmental factors at different levels, including family, community, and the healthcare system, as well as the individual. These factors can then be classified as modifiable or non-modifiable. These modifiable factors that we determine are the key targets for intervention. That's what we need to hone in on because we can make an impact, potentially make an impact on them. One mistake healthcare providers may potentially make is providing self-management support without taking into consideration the environmental factors. It is so important that we ask about the home, school, and community environments to identify factors that may positively and negatively influence a child's ability to perform self-management. So with all that being said, I want to switch gears a bit and share some of the practices and tools we have been using in the complex care program when supporting self-management among our patients and their families. First, I want to start off by stressing that self-management support is truly a team effort. It takes everyone in the child's life, from the healthcare system to their school, to their community, and their entire family. So it's not just the provider that's performing this. I rely heavily on each of my team members to help me with this process. When I first read this research article, 2 of my biggest questions, as a healthcare provider directly supporting these families were these 2 questions. How do we transition control from the caregiver to the youth? It seems like a very, very big daunting process. It can be overwhelming. And my second question was, how do we calibrate to the unique needs and skills of each medically complex child and family? Again, it's not easy. Parent and caregiver involvement is key in encouraging self-management behaviors at different different stages of the child's development. I think this figure here, it does a nice job outlining the potential evolution of shared management between the caregiver and the child. And it shows over time how the parent gives up more and more responsibility to the child. I think it is also important to note that each child's potential is different depending on their conditions and their disabilities. Not all children will be able to get to the manager or supervisor role, and that's okay. And each child will transition through each of the roles at their own pace, and that is okay as well. For those children with disabilities that limit their abilities to participate in self-management, there are still things we can do to support their self-management. Different examples include, continuing to promote independence, simplifying their routines, providing adaptive supports, setting realistic goals with them and their parents, and empowering the youth to develop new skills. On this slide here, it's just an outline of what I'm going to talk about next. So another question I had was, what are some feasible practical tools to bring self-management into practice today? And the items I'm going to talk about here are social history, the shared plan of care, goal setting, and then the youth to adult transition planning process. I appreciate that the journal article and the two frameworks point out the importance of understanding the environment a child and family functions in, and really understanding the modifiable and non-modifiable factors in their lives, because this is key to setting the children and their families up for success. A standard approach we have taken in our complex care program, and I think a lot of healthcare providers already do, is obtain a detailed assessment of the child's environment. And we do this at our initial enrollment visit. In medicine, this is what we call the patient's social history. Our providers and social worker ensure this information is in the child's chart under their social history, which is easily accessible to providers within the health system. This slide here provides an example outline of items that we ask our families about. Specific things, include who the child lives with, caregiver occupations, what their housing and transportation situation is, family supports, school, therapies, religious or cultural considerations, activities that the child enjoys, and appointment scheduling preferences. Having the child and family's preferences, strengths, and potential barriers in the chart allows for a rapid assessment of the child's environment, especially for specialties that are pressed for time in clinic visits. With this, they can easily and quickly get a sense for possible strengths and barriers the child may face when they are making recommendations about treatments. A child's environmental factors are dynamic and they're always changing. However, I found it very beneficial to get a thorough social history up front and then build upon it and update it with each patient encounter or clinic visit. Here I want to talk about the shared plan of care. Most or some of you have probably heard this buzzword going around. In the last year or so, our complex care program initiated the development of a shared plan of care for each of our patients. Among other benefits, this document has provided a consistent avenue for our team members to support self-management. The shared plan of care, it is a comprehensive document that contains specific elements that are addressed for each patient. The document includes each of the following sections that are here on this slide. So it has a who am I or a patient description. It has a self-management intake, and I'll go over that a little bit on another slide. It has a plans of action and goals section. The contact information to get a hold of our program. It has a detailed problem list with their medical conditions on it. It outlines the youth to adult transition planning process, has their medication list, and then it also includes that social history that we go through with families, and then any other important items that we want to add to it. Our providers create this document after each clinic visit, so at least twice a year we see our patients, and then place it in their medical records so that it is readily accessible by all providers in the health system. It is then given to the families, who can then share this document, outside the health system, so to outside schools, therapies, and other community resources that they wish. This document provides several key elements in supporting self-management. And I'll go over some of them right now. So creating goals with children and their caregivers is a part of each of our visits. And so during each of our follow-up visits, our team creates a to-do list or like an after-visit summary that outlines action items each team member or patient caregiver are responsible for. Within this document, there's also a section on goals for the patient and the caregiver. This is a time where we specifically take time to discuss goals and collaboratively create goals with the child, if they're able to talk or be cognitively able to do that, and then the caregiver. And these most often include self-management goals. Creating effective goals, it's not exactly an easy skill, and it takes deliberate thought and practice. I personally have been learning how to create SMART goals, which means they are specific, measurable, achievable, relevant, and timed. Then at the next follow-up visit, I pull up the goals that were set at the previous visit, and I, in collaboration with the child and caregiver, determine if these goals were met, not met, or if they're continuing to progress towards that goal. If they seem to be stuck or unable to attain the goal, I like to try to get the child and the caregiver to think about barriers that could potentially be impacting their ability to achieve that goal and how we can overcome those barriers. And if they've met a goal, that's a great time for us to celebrate, and then we move on with creating new goals. This is kind of a long slide here, but I think it is pretty powerful to get a parent's point of view with this. It's an example of the essence of setting realistic goals. And this quote is from a mother of a child with cerebral palsy. I'm going to read it for you. So from my experience, I find a few points handy when setting realistic goals, breaking goals into shorter targets spread over a longer term. My daughter's neurologist explained this very well. He said that your child's growth curve won't be in a straight line. There will be high points and low points, but overall the curve should be moving in an upward direction. Thus, for my daughter who has cerebral palsy and cannot walk independently, I have broken our goal to make her walk independently into several short-run steps or targets, which would include walking functionally with a walker, then walk with quad sticks, then walk with single point canes, and so on until she can walk independently. And so she needs to cross all of these phases to be able to walk independently. Setting short run targets, such as walking with quad sticks, allows us to work towards a realistic target, which can be achieved and celebrated, instead of setting a longer term goal, which is so difficult that it is impossible for my 4-year-old to comprehend at this point. I thought this was a pretty powerful firsthand experience of a parent in instead of setting these big goals, setting these small stepping stones to an ultimate final goal. So this here is part of the shared plan of care, and it's the self-management or youth to adult transition summary that we fill out with families. So when our patients turn 12, we start spending more and more time at our visits discussing the youth to adult transition process. And for part of this process, we have created this self-management summary that we fill out collaboratively with the child and the caregiver. This is then placed in the shared plan of care, and at each visit we review this summary and build upon it. And the reason why we put this in the shared plan of care was we wanted the child and the caregiver to really have a voice and make it known what they want their pediatric providers and then the adult providers to know about them. So for example, it tells how do they communicate, what hurts me and helps me, what makes me anxious, what a good day looks like. So that provider can really get a sense, how to approach the child. And then the two items on the bottom, I think, really hone in on that self-management piece. And so it is, it gives the family an opportunity to think about, what do they do for that child, and then what the child can actually do for themselves. And I have found in my experience, the child that can communicate to me are really excited to fill out this piece because they're really proud of what, they're able to do. And it allows a good segue into creating goals for more self-management behaviors. Just like to note that it takes a village to raise a child, and it definitely takes a village to, raise a medically complex child. It is equally important for the people in the child's life to be aware of the goals. And we want to align goals with schools, therapists, community supports, and all the parties involved. And so again, we encourage patients and their caregivers to share their plan of care with these supports outside the healthcare system, so that everybody, ideally are on the same page and can collaboratively work on these goals. And then, as I mentioned before, when a child turns 12, we spend time during our clinic visits counseling on the youth to adult transition process and preparing the child and family for this very significant and complex transition. Our program has created a transition checklist that helps us guide our patients and families through this process. And the following slides include items on this list. So let's see here. So ideally, you'd be looking at a full comprehensive list, but I'm going to break it up into the age ranges. So for example, at our visit, if the child is between 12 and 13, we introduce the transition topic to the family. And then this is a time where we start discussing confidentiality with the teen and the family and allowing one-on-one time if they're developmentally or cognitively appropriate. So it just kind of starts that self-management process as a teenager. For the middle teen years, this would be between 14 and 15. So when we're seeing them at this age, we like to discuss what healthy means. So what does it mean for that child to be healthy? And again, including independent times during those visits. For the later teen years, this is a time where we start talking about post-high school plans, talking about insurance knowledge and coverage after adulthood. And during these times, if the patient is cognitively able to understand, they are very actively involved in these conversations. And this is another time where we're encouraging self-management. So having them understand, how to make appointments, learning how to advocate for themselves, knowing what their medications are, how to get medications. And then we also start talking more about the legal implications of turning 18. So if they're able to, make their own decisions, or if we have to get guardianship for the parents, we start talking about what that looks like. Then when they turn 18, or they're in their young adult hood, this is the time where we're also determining which providers they're going to be going to in the adult world, but we're continuing to assess their readiness and skills, if they can, support themselves, or if they need their parents' support or other support in the communities. So really with this whole checklist, it's a great opportunity to be, really honing in on self-management skills and determining where that child can get to. All right, so that's my presentation. Thank you so much for letting me talk about this topic. Again, I'm by no means an expert in it. I'm constantly learning about self-management and how to best approach this, with our medically complex patients. So I definitely look forward to questions and discussion here. So thank you.
Thank you so much, Melissa. I apologize for misattributing at the beginning of this. Totally my responsibility in the way that I had things written down. So I greatly apologize for that. We'd like to open up now, for we know we have providers and from different clinics and from different agencies and even from outside of healthcare, but we'd like to take this moment to discuss the presentation, any questions that you might have for Melissa or insights from your own experiences. Please feel free to unmute yourself when you want to talk, or you can also put your questions in the chat box and I'll repeat them for the group, and please make sure you have put your name and your organization into the chat box for attendance reasons. Thank you. Questions, comments?
Hi, this is Meg from the South Regional Center. Can you hear me okay?
I don't think we can hear you.
No. Meg, could you speak up, please?
Yeah. Is this better?
Not much better.
Okay, hold on.
Could you yell at us, please, Meg?
Or use the chat box.
I think I'm going to use the chat just because I can't really my mouse is running.
While Meg is typing, this is Ann Harris. I did have a question about, you mentioned that you do the shared plan of care with all of your patients. So how, I was just thinking about how that works for the team and if it's just, you know, like done at a particular visit, or how do you figure that out?
Yes, it has been. I think Tim can probably attest to this because he's been, he helped us with it as well. So it is a document that it's at every follow-up visit. So with our program, we have to see our patients every 6 months at a minimum. And those visits are, you know, at least 50-minute visits. So we're very comprehensive with it. And so at that time, you know, like, for example, the self-management or youth to health transition process, we'll collaboratively fill that out with the families, but that document is not created right at that visit. We have to like update our problem list and, you know, update the social history in that. And so it actually gets mailed to our families within, like, I would say a week or a week and a half after the visit.
Great, thank you.
Hi, Melissa.
Yeah.
Yeah, hi, this is Judy. And I'm a little curious about, can you tell me a little bit about, or tell us a little bit about what the role of the physician, the pediatrician or the pediatric specialist is in this, in terms of, do they have any communication with the family about all of this, or is it pretty much like social worker nurse role? And then also, to what extent, if any, do they participate with identification of an adult provider?
Yeah, good question. So the actual shared plan of care is created by the provider, so either by our physician or one of us nurse practitioners. However, our social worker or our nurses can update like the social history piece of it. They can update the goals. So everybody can kind of touch that document, but it's ultimately created and sent out by the physician. And then as far as the pediatrician, so we definitely advocate for our patients to have, you know, keep that relationship with their primary care provider. And we don't collaborate. To date yet, we haven't collaborated with the primary care physicians to create this document. I definitely think that's an area that we can look into because we definitely want to partner with them and be on the same page. And then as far as determining an adult primary care provider, we definitely rely heavily on the their current pediatrician. And it's more just kind of word of mouth, which primary care providers, like taking care of medically complex youth or young adults. Does that answer your question? I don't know if I answered that.
Yeah, that's fine. That gives me a little bit of an update as to what the current practice is at this point. So thank you.
Thank you.
This is
Hi,
Meg.
Melissa.
Hi.
Hi, I'm sorry to whomever I just interrupted. This is Geeta with the Wisconsin Medical Home Initiative, and I want to ask you a two-part question about the shared plan of care and your clinic's efforts around the conversations you're having with families to share that plan of care, and just thinking about a little bit about what we've heard from families, that there's a lot of great information in there, but they might not want to share everything that's in there. So I'm curious about how you're messaging or having those conversations with families about sharing them or how to use it, and then how do you honor your family's requests around trying to modify that shared plan of care so that whatever's being shared is only what the family wants shared.
Yes, that you bring up a really interesting point, and I don't think I have actually had it brought to my knowledge, that families are maybe sensitive about certain parts of that. So I'm glad that you brought that up. I think that we, talk about this document broadly, in that, it's a comprehensive document, and a lot of times we, push families to have it on hand to give to emergency departments if they go to them. And I don't think we as strongly advocate as good as we could to, get it to their community resources. We kind of brush over that, but, with this presentation and doing it more, I think we need to have a better effort in explaining, the different ways that they can use it as a tool. And I guess I'd be curious to learn more about like what sections families don't want shared, because it is a template, but I think we are very flexible as, a program, and realize, there are probably certain things that they might be sensitive about. I think we just have to work with them on that. Ideally we want to have a document for them that is going to be useful and effective. So are you able to elaborate a little bit on like, for example, what families don't want shared?
So my knowledge of that would probably come better from some of my team members who are on the phone, who have had some better conversations. And certainly if they don't have that information in front of them, we're happy to circle back with you at another time. But so I can't give you specifics at the moment. This is just sort of secondhand information that I've heard from my team.
This is Becky Burns. I'm part of that team, and I might be the source of where she heard that from. So I'll offer that my experience has been that for some families, and these may or may not be families that you're working with, are hesitant to have their school staff know all about their kind of being up in their business, so to speak. So knowing all of the details of the medical, if it's above and beyond what they would need to know to support the child's health throughout the school day, especially if they're in any kind of conflict with the school, maybe the school's not upholding their end of the bargain and the IEP. And so then I've seen some hesitancy in some parents in not wanting something like a shared plan of care being shared openly with their school.
Okay. And I think one thing to note with this is this shared plan of care can, on our end, can only be seen in their medical record. It's up to the families to share it with anybody outside the healthcare system. But I think you guys bring up some really good points, because yes, they are very in-depth documents.
And this is Tim, and I just want to bring up what I really appreciate. One of the things I appreciate about the team over at AFCH is the fact that they are very sensitive to what the family and the other providers that I met, very sensitive to what the providers, to what the families want shared. And so with that whole shared plan of care, it's like, okay, this is all the information, but you do have the decision, you do have the power, it is your right to disclose. And I haven't, seen any of the providers that I've worked with, insistent upon it. And so I really, that just goes back to one of your main points, Melissa, about involving the family and the youth from the get-go, in what it looks like, and that this is a process. So I really appreciate that.
Thank you.
Okay, this is Meg. Can you hear me now?
Yes.
Excellent. So my question has to do with how do you help or guide families to make that shift if the child has capacity to do stuff? Because my experience has been with families, it's like, oh, this kid is going to need a guardian. I'm going to have to make all their decisions, when in fact, that might not be true. So I'm just curious how you would approach a family like that.
Yes, that is probably the biggest overarching question for us taking care of these kids. I have found that it really takes time and building a relationship with these families. Like, I can't just go into a visit and if I haven't met that family, and this child with a lot of medical complexity, and just start saying, no, this kid can do this, this, and this. No, you have to really build a relationship and their trust, and really, get to know their dynamics and their situation, their environment. And then this is a learning process for me too, but at each visit, I just kindly, setting those goals, having those conversations, and kind of gently nudging them, with the caregiver and the child there. So, and kind of forcing them to have that conversation. I find a lot of times, these kids, when they're first born, they're very, a lot of times they're really complex when they're younger, and then they kind of grow out of that complexity over time, or you're not in as crisis mode. And I think the parents are so used to just providing all of that care, and it's almost like they need that permission to be like, it's okay, you can loosen up the reins a little bit, and let's start, having the kid, just do little things. Starting little and, working on those stepping stones to the larger goals. And again, I have to give credit to, our social workers and our nurses, because they are, talking frequently with these families as well. And so they're, also helping these families along in each of their interactions.
This is Tim. I just want to make a quick note for the people that are on the phone. Is that Kara from AFCH also commented in the chat box that social work at complex care. Just wanted to say that they only disclose to the school if parents specifically ask for it. They can always share parts of the plan of care, as well as leaving out pages or blacking it out. And they always ask the families to do this themselves on their copy, as they are providing it to the school. Further questions, comments, discussion?
Hi, Melissa. This is Colleen Lane with the Medical Home Initiative with Children's Health Alliance of Wisconsin. Thank you for your wonderful presentation. And I'm wondering, I know you specifically mentioned that it's challenging to set goals, having the families work on their goals and so forth, and that you've been learning how to use SMART goals. So I'm wondering if you've had any experience in the last year using, what successful strategies have you found in helping families to determine their goals, or if you found anything that has been helpful?
Yes. A lot of times what I will do is the parents will kind of bring it up, like, they want, for example, let's say they want their child to, learn their medications, or, remember when to take them. And so the parent will kind of bring that up, and then, I'll look at the child who's kind of sitting there like, what? And start that dialogue between the parent and the child. And because I can come up with a plan for them, but it may not work for them in their environment or with their schedule. And so I kind of act as that mediator between the parent and child and kind of have them come up with, you know, the goal or, you know, the plan for that goal that's doable. Because then when I see them the next time around, I can kind of hold them to that. And if it didn't work, then to start that conversation again, like, well, what barriers were there and how can we overcome that?
Thank you. I think it's apparent that you your communication with the family and the patients is priority, and so thank you.
Yes, thank you.
And working with them to determine their needs. Great.
Any other comments or questions? I would like to take this opportunity to invite our partners at Wisconsin Medical Home Initiative. If they would like to give a brief update. I know that most of the people on the call are familiar with the quality improvement grants, and just if there is a timeline or information for the next round of grants that may be coming out. Geeta or Colleen, if you could give us an update on that.
Thank you, Tim. I'd be happy to. Just a brief little introduction or overview is that the Medical Home Initiative of Children's Health Alliance will be releasing the RFA for next year, for 2020, and that will be released on October 7th. So the material is released, the grant guidance and the application, and so I do work very closely with the Wisconsin Youth Health Initiative to release and promote that information. So again, the RFA it's really out to support implementation of a medical home quality improvement process, and through the use of a shared plan of care. So Melissa very conveniently has mentioned her use of the shared plan of care and how it can work within that transition focus. So that is the youth health transition is again is a focus, additional focus that teams can choose to work on. But again, more information will be released for the 2020. So the work would start on January 1st and then go till December 1st of 2020. And the applications will be due by December 2nd. So thank you, Tim.
You're welcome, Colleen. And just a quick question, will there be the opportunity for clinic teams that have received a grant before to apply for a grant again?
Yes, there will be the opportunity. So if you are currently doing the work, the opportunity does exist for those teams to apply again, as well as new organizations or teams that are interested in the work.
Thank you. And if you need more information, as those RFAs come out, keep an eye on the Wisconsin Medical Home Initiative website through Children's Health Alliance. At this point, we have completed the goals for this learning community. We ask that you would complete the evaluation at the link in the chat box. We really need to ask that you would rank possible topics for future learning so that we know what you're interested in, so we can provide interesting topics and quality content to our healthcare transition champions like you. Thank you so much, Melissa, for your time and effort at putting in this presentation. We greatly appreciate it. Our next call is November 14th, Thursday, and we'll hope you'll join us. Your input from the evaluation will determine the topic for that call. Thank you for your participation, and this concludes our presentation. Have a great rest of your afternoon.
Thank you.